Are we able to the roles? Okay. Thanks everybody. This is the last Saturday meeting for the year, Saturday Noon Meeting. And thanks to all of those who've joined online. I just want the online people to know that we've got a sizable audience in the room as well, which is unusual for the Noon Meeting. So it's going to be a juggling act to balance both the online and the in-person venue. So thanks very much to SIDA and the Division of Public Health Medicine who have come out in numbers to support us today. We are going to hear from one of our PhD students, Kathleen Kehoe, who is doing her PhD on a number of aspects of infectious diseases in children in the Western Cape. But the particular analysis she's going to be presenting is really looking at the infectious disease admission burden during the COVID period. And Kathleen, just to mention, is one of the cohort of COTEL students who are going to graduate next year. I think at the moment they don't feel like they're ever going to graduate, where they are going to graduate both from the University of Bristol and the University of Cape Town, which is a good thing, but has also presented a number of challenges along the journey in trying to meet the requirements of two universities who don't always want to see eye to eye. So congratulations to Kathleen for navigating that journey, and we look forward to your presentation.
Thank you, Ryan. Afternoon, everyone. Nice to be in person for a change. It's been such a long time. I think the last time I was here was in 2019, so it's been a little while. The analysis that I present to you today is from two of my objectives. My second and third objective is focusing on LRTI and diarrhea admissions in the Western Cape. So I don't think I need to tell you guys much about the COVID-19 pandemic, but just as a brief background, the COVID-19 pandemic and, the South African government response affected infectious disease transmission, healthcare access, and population mobility, and created a whole subset of issues that we're all well aware of, one of them being public fear due to COVID-19 infection. And to kind of curb this, there were different things that were put in place. One of them was to reduce non-essential health services. And in the Western Cape, that was specifically done by postponing elective surgeries, longer routine clinic and dispensing intervals for chronic diseases. But some services were maintained, such as childhood immunization. And we see really high coverage rates besides the Q2 dip over this time period. So there were several public health and social measures, or PHSMs, aimed to curb the SARS-CoV-2 transmission and to really protect our healthcare system to ensure adequate hospital capacity for COVID-19 admissions during this time. So as you guys know, the initial measures were implemented in March 2026, and were based on our anticipated burden and really the identification of the first reported case in South Africa. And then we had subsequent in and out, and these were really based on COVID cases and hospitalizations. And this was all done at a national level, irrespective of burden in provincials or subnational level. And as you'll see later with some data, it didn't necessarily correspond to the Western Cape's COVID-19 peaks that we saw in the province. And so in order to prepare for pandemic responses in the future, it's important to evaluate the impacts that these PHSMs and COVID-19 burden had on LRTIs and diarrhea, which are, as you guys know, pre-existing conditions of concern among children in South Africa. So our aim was to assess childhood under 5 LRTI diarrhea admissions and LRTI hospitalizations during COVID-19 surges in relation to the PHSMs in Western Cape public health facilities going from January 2019 to November 2021. So in 2022, the Western Cape had a mid-year population estimate just about 7 million. 8% of those were children under the age of 5, taking that just above 500,000 children. 75% of the population here access the public healthcare sector, but we imagine that this is higher in children, around 80%. So we included children under the age of 5 who had either hospitalized or died from an LRTI or diarrhea during their admission in the Western Cape across these facilities for January 2019 to November 2021. So a lot of my work, my PhD, has been creating a consolidated data set that searches for different infectious disease admissions and deaths, and using the base table that I created for The first objective, I created a consolidated aggregated data set. This is aggregated by location and calendar month. And this is heavily reliant on data from the Western Cape Provincial Health Data Centre, which feeds in data sources from several systems. And this relied on routine health information systems such as Clinicom, ChildPIP, and then the death notification specifically for deaths. And then we also use population estimates that come out of the PHDC. And then in terms of the geographic distribution, excuse me, we map children to their most recent place of residence, and we distributed our population. And there's one metro that got further subdivided into the 8 sub-districts, given on healthcare access variation, and then our 5 rural districts were separated out. So just a little reminder of the PHSMs in place. We had really stringent measures for a very long time in South Africa, which ranged from restrictions, curfews, school closures, which are particularly important to this population, masks, and then sanitizer distribution. Our analysis only went up to November 2021, post the last major healthcare wave, and no further PHSMs were really introduced afterwards. So we kind of have different time periods in this analysis. So looking at the overall time period, which I've mentioned, then we have a pre-pandemic time period, which goes from January 2019 to March 2020. And then we have our pandemic period, which is April 2020 to November 2021. These are further subdivided into tightening and relaxation periods of PHSMs, and I'll go into more detail on that in a bit. So our main analysis is looking at an interrupted time series analysis using negative binomial segmented regression, which considers both the level and change range for these diseases independently and allows for random effects by location, given that we think there are differences in access to healthcare across these locations. And then we reported out a step change, so that's the immediate change after the introduction of the interruption, which is PHSMs in this case, a trend change. So how does that change over time in your post-interruption period? And then a post-interruption trend, which is the combination of your interruption, yes or no, and then the by calendar month. So it allows you to estimate a post-interruption trend by month over time. So we were able to only adjust for a subset of potential confounders based on what we had available in the data set. This included sex, age, duration of admission, quarterly proxy immunization coverage, which used the HIS data for Johnny, and population estimates, the COVID confirmed admissions, we also have cases, and then seasonality, which was defined for each disease respectively. So this is looking at the first outcomes for LRTI, because we looked at the analysis separately. So the first column is looking at the overall time period. The pre-COVID one is our pre-pandemic, and then our pandemic time period. So with the blue boxes, if you just look at the top half for LRTI admissions, you can see that most of our admissions are males. They were in younger children from neonates to the age of 1 year, and then very few COVID admissions. And this kind of distribution that we see overall remains true for both pre-COVID and COVID time periods in terms of admissions. When we go to the bottom half of the table, we're looking at RTR deaths, which is coded up using the ICD-10 codes. And you can see there's kind of a shift in characteristics. So we had slightly more males during COVID. There was a lower median age of death from 6.8 to 5.6 months. And then we have a slightly different, almost a halving of median time from admission to death for these children. So this graph is looking at kind of the combination of the effect of LRTI admissions and COVID admissions. So we have our time there, going from January 2019 to November 2021 here. And then the lines are reflective of the different PHSMs which are implemented during this time. So red in this case means bad, so the tightening of the restrictions. And then the gray line is a relaxation, still the presence of PHSMs. So if we just look at this gray line here, that is graph, that's our 7-day moving average of COVID cases in the province. And you can see for wave 1, which is here, and 3, this first and third implementation, it's kind of more of a proactive response that was happening at a national level, but really happened before the peaks of the COVID-19 waves in the Western Cape. And you can see in the second one, it was a bit more reactive, and the Western Cape already had peaked in terms of COVID-19 cases at that time. And then if we just look at the blue line, that's our 7-day moving average of LRTI admissions. And you can see our typical winter peak there in pre-19 that we expected during super surge season. And you can see a very dramatic drop in cases post that first introduction of PHSNs. So then the blue arrows are just kind of indicating our expected seasonality for these cases. And you can see that we kind of had a shift in that. And it's mostly predominant. Like in 2020, we kind of see it just playing out in a similar way to 2019 as it does in 2021 for this peak year. So this is now looking at LRTI admission rates for children. So if we just focus on the first 2 rows, that's our overall time period again, just pre-COVID versus pandemic. And you can see the number of admissions are pretty similar, but we see a drop in admission rates from 13.2 to 9.94 during COVID. And then if we look at the bottom half of this table, this is now when that COVID-19 period is further subdivided by different implementations of the PHSNs. And you can see there's a dramatic drop during this first implementation, almost halving from what we saw during pre-COVID, and has the lowest admission rates over time in the analysis. And then the grey kind of, the red ones are the tightening, right? And the grey ones are the relaxing, corresponding to the graph earlier. But you can kind of see that they increase during relaxations, except for this last one where it remains pretty similar, but a short amount of time was included, given when the analysis was cut off. This is now looking at the outcomes of the interrupted time series analysis. So this very first column here is just looking at the entire time period. So COVID-19 versus pre-COVID-19 without interaction happening in April 2020. And so if you look, the first one is reporting a step change, which is that immediate impact of the drop in cases that you saw. So we see about a 13% step reduction in LRTI admissions. And then our average post-interruption trend of the incidence rate ratio is 1.02. So we, on average, we're increasing LRTI admissions by 2% every month. The next part of this very long table is again subdivided into the different PHSNs, red being the tightening and grey being the relaxing. And so again, you can see this very strong effect of decreasing in LRTI admissions immediately after the introduction of PHSNs, the 38% reduction on incidence rate ratio 0.62. And then you can kind of see over time it increases a bit more in that initial period than when we just compare COVID to pre-COVID. And then when you kind of look at the fluctuation over time, step increases were generally associated with increases of relaxation, so these grey boxes here, but there's a diminished effect over time. We also did the same analysis and we excluded children who were confirmed COVID-19 infected, and we saw similar changes in the incidence rate ratios. So this is now looking at trying to figure out what would have happened in the absence of PHSN introductions, so counterfactual analysis. So here you have time for the entire analysis going here, and then these are LRTI rates, which are either actual model predicted or counterfactual. It's really hard to see it on here, but this purple line is looking at the counterfactual predicted LRTI rates. So what we did is we modeled this pre-COVID-19 period, excluding COVID cases and the interruptions, and then we applied that and forecasted our rates out forward. And what you can see is that we actually expect a much higher number of cases than what happened during that first time period. And then the 2 grey lines, the darker one is the model predicted lines, which is just speaking to model fit. And then the lighter grey line is the actual observed ones that we see over time. And you can see this higher concordance as further away that we move from that first interruption. So next, moving on to diarrhea, it's exactly the same analysis, but modeled separately. So you can see that most of the admissions during the top part where we were just looking at diarrhea were male, and we had very few ICU admissions. So the same kind of thing that we saw for LRTIs, except there's kind of a change in the age group where predominantly older children are experiencing this as an outcome. And then in terms of the bottom, when we look at deaths, Again, we have slightly fewer males dying from diarrhea during COVID than pre-pandemic. We have a lower median age, which was the same what we saw in the LRTI outcome, and then a very similar median time to death with 1 day of admission for each children. This is now looking at the same graph with just diarrhea as the outcome. So again, we have time at the bottom here. Our blue line is the diarrhea outcomes, or the 7-day moving average, and then the grey line is our COVID cases. And then red being the tightening of the restrictions and grey being the relaxation. And you can see we don't have such a strong pronounced early peak, but you can see a reduction here in cases. And then our second largest reduction is seen in the fifth implementation of the PHSNs. And then when we look at kind of when we'd expect to see a summer surge, you can see it kind of happening in January 2019 and January 2020 around those time points. It kind of disappears during that January 2021 time period. We know there was implementation of children staying at home due to extended vacations. And then we kind of have an unexpected surge here with the diarrhea cases, which kind of corresponds to a change in PHC head count that we saw during that time as well. So now just looking at the diarrhea admissions, overall you can see there's quite a few less, but almost half the number of diarrhea admissions overall. But you can see the admission rate does drop the same as LRTI. So we went from 6.39 to 4.62 from COVID to pre-COVID. And then when we subdivide that further into the different implementations, again, you see that there's quite a steep decrease in that first implementation to 2.55 admissions per 1,000 person months. And then the third implementation, which is that just before you get that peak in May, we have an increase from the preceding time period, and it's kind of expected given what was happening during that time. And then during the fourth implementation, we had quite a high number. You can see there's a high number of admissions, the highest during that time, at almost 3,000, and corresponds to quite a high admission rate. So this again is looking at the interrupted time series analysis outcomes. So that first column in blue is looking at COVID-19 pandemic period versus pre-COVID without interruption in April 2020. And so our immediate state of change after the introduction of PHSNs is about 14% step reduction in LRTI admissions. And then we see a gradual increase over time at about 2%, which is the same that we saw for LRTIs. When you look at that first implementation in red, which is the strictest lockdown, you can see we halved diarrhea admissions during this time, but quite a steady increase at 17%. And you can see that as the graph goes up over time. And then as you look at kind of how they fluctuate in and out, when there's tightening of the PHSNs, we have a reduction in both our step change and our average post trend change. And kind of an increasing or stabilization when there's relaxation, and then a very sharp increase at the last implementation, assuming that we were going into the summer surge during that time period. So this again is looking at what would have happened in the absence of PHSNs under the expected seasonality. So the two grey lines again are looking at model versus observed, and you can see over time there's quite they match each other, especially at longer durations post that first interruption. And the same thing is true here. So this is the purple line. So we actually expected a much higher admission rates for diarrhea in April 2020 than what we observed. So just in summary, the greatest reductions were associated with strictest PHSNs, and the greatest declines were noticed with that first introduction when we had the strictest lockdown in South Africa. This is more pronounced for LRTI admissions, which kind of makes sense given that respiratory tract infection was similar in nature, whereas diarrheal transmission happens differently. The tough thing to associate to kind of look at something like this is that there was simultaneous introduction of a lot of these things. So school closures, social distancing, hygiene practices, were happening at the same time as healthcare access was changing due to mobility restriction or fear. And so it's really hard to disentangle those in an analysis like this. But when we look at those graphs over time, it seems that they are more related to the PHSMs rather than the burden that the healthcare system was facing at that time, given when the COVID peaks were happening in the Western Cape. What we saw is children dying from these diseases were generally younger and had shorter time to from admission to death, suggesting that more severely ill children sought healthcare or faced healthcare access challenges during PHSMs, worsening their presentation on arrival to facilities. And so just some strengths is that we used individual level data, even though this was aggregated by location and calendar month, and this allowed us to have outcomes for all these children using the data linkage to the PHDC. We had a complete data set, well, as much as we could, for the Western Cape, increasing generalizability of these data. We used an extensive ICD-10 code list to identify the LTI outcomes and diarrhea outcomes and research this across all available ICD-10 codes for these children. And then furthermore, we mapped these children actually to their most recent residence location rather than facility based on how hospitals are based located across the province, revealing some further insight into the community's disease burden. There are several limitations as usual, because we aggregated this up to the closest month. Sometimes the PHSMs were falling within a particular calendar month, but we use that by using the nearest month for the interruption. So there's red and grey lines over time. We unfortunately haven't had access to out-of-facility deaths for my whole PhD, which makes it a bit complicated. And we suspect that these probably increased during COVID, given healthcare access challenges. And we know that from other data that was published using the HIS centers that pneumonia and diarrhea remained one of the main causes of death in children during the pandemic, despite decreasing in overall numbers. We solely relied on our electronic health records. However, we do believe that completeness was high during this time period and also increased during the pandemic. And this would have possibly underestimated the PHSM related reductions. And then given that we're only limited to hospital admissions, not all touch points with the healthcare facility, this may limit our understanding of COVID-19 surges and the related impacts of the PHSMs. We also were limited to what confounders we could adjust for, given what we had available in the data set, particularly when it comes to socioeconomic status. That was really challenging, and so we had to really rely on sub-district or district as a proxy for that. And then given that we had to combine multiple data sources, we were limited by the availability. So child's residence was used for hospital data and population estimates, whereas immunizations, live births, and COVID-19 cases were based on healthcare service location. And then when we were calculating the rates, we're using that 8% of the population, given that's how many children we think access to public health services. So we changed that assumption on how many children rely on these services. But changing that it would change the rate, but not the estimated trend over time that we're seeing. So in conclusion, COVID-19 surges and associated measures were linked to declining admissions, likely driven by a combination of reduced infectious disease transmission as well as healthcare services, although we see this effect diminishing over time for both diarrhea and LRTIs. And then these findings may inform future pandemic responses and policies, with a focus should being on balancing the short-term benefits of reduced transmission and preserve healthcare capacity for pandemics, as well as considering the social cost, which is not very sustainable. And these are my knowledge.
Thanks very much, Kathleen. That was great. And very quick. That's that people didn't catch, but thank you so much. And a huge amount of work to put the data set together in the first place, never mind do the analyses. And I know there's some nodding heads from people who work with PHDC data and know the pain that you've been through. I'm wanting to go out of this so that we can see if there are people in the chat or comments or questions from our audience as well. Okay, so we have our audience and people here. While people think about questions. Maybe one thing just to highlight, people may have missed it, is so during that December 2021 period, no, December 2020, which was our second wave, we would have expected a diarrhea peak there. So we did see an increase. It was quite weird. When you talked about your rates of admissions, we could have gone back to the slide, I suppose, but I'm not sure if we can. They actually went up in that period, but they didn't go up that much. And that was possibly because school stayed closed for a very long time. It's the one thing I wanted to add. Are there any questions, Emma?
Yes, please. Thanks very much. This is amazing. And I'm going to ask you for help on the interrupted time. So you have did the immunizations, was there an impact on immunization?
So no, not when we looked at the data. It was actually quite challenging to create a proxy immunization coverage. I think we went back and forth several times on what the best way to do that is. So we took Sanjani data and we used fully immunized under the age of 1. And when you look at that, just in terms of crude numbers, you only really see a drop in like April 2020 to June 2020 time period. Otherwise, it's sustained after that. And then to calculate the immunization coverage, we then took the population estimates that the PHDC produced from the previous year to create a proxy eligible cohort. But because we had monthly data, not annual, we had to kind of come up with some measure that wouldn't look really poor. And so we took
meeting in Joburg is feeling
Sorry, can we ask everyone online to mute?
for various reasons.
And so then we took the live births by quarter and we applied that to the proportion of population estimates to get a population denominator that would allow us to get a proxy immunization coverage that would make sense. Otherwise, you get really low rates of around 20%. But it did stay quite high, around 80%.
I saw another review, I think it was based in Pretoria. And there are also interventions that happen at school. It's not immunization, but you get like vitamin A and deworming and things like that. So the closing of schools may also indirectly affect the severity of diarrhea and MRTIs if you don't have that sort of thing. If those services obviously fall away completely.
And food.
And food, yeah.
Although these were under 5s, but
Yeah.
ECDs and pressures, you don't pay fees and get food.
And get food, yeah.
Yeah, so
That's great.
firstly.
So no, it's fascinating. So see, the difficult thing is which of the interventions made a difference, and you can't tell that. I'm just wondering if Ms. Mills work around alcohol and trauma, we had to separate out the curfew from the impact of alcohol ban on trauma, would help tease out, whether it's the lockdown, whether it's the social distancing, whether it's the hand, what of those things are. If there's any way of teasing that out, or whether we just accept it as no way of understanding how it works.
Yeah, I think there are like more complicated models that you could potentially look at to do this. I think it was too hard for us to tell, given that we are so aggregated up to the month in terms of when those like the implementation of the PHF things happened. And so I think we kind of just went with it's a combination of things, and we're not really sure what is attributed to it.
I think Ms. Mills actually online, so he may want to comment if he's there. I know with Ms. Mills, I was involved in that analysis because the alcohol ban and the strictness of the curfew didn't always exactly coincide. I think there was some way of taking that into account, and he had quite nice nuances of the alcohol ban in terms of, a total ban versus some restricted trading hours, etc., that he could look at. Ms. Emile, do you want to comment?
I can, yes. Thanks so much. Firstly, Kathleen, an amazing presentation, and well done for diving deep into ITS. I can speak from experience that it's not an easy type of analysis, but I think it certainly added value in terms of the stuff that you've shown. I mean, I'm interested in a couple of things. The first maybe to say is that, okay, from my side, the alcohol bans and the curfew, oftentimes they coincided. So separating it out was quite difficult. I looked at availability of alcohol, which is slightly different, and curfews actually as an effect modifier would in effect reduce availability. But and we could separate it out in terms of which lockdown levels. I'm interested in the fact that you've actually aggregated your restrictions to a monthly level, and I'm wondering, sort of, is there any mixing of effect if your restrictions are at a monthly level, but your outcomes on if I understand correctly, on a daily level? Is there mixing of effect in terms of actually the reduction or the increase in outcomes? And then the other thing I wanted to ask was your issue of seasonality. Did you, and maybe I missed this, but did you use pre-COVID data to adjust for your seasonality variables, or did your model account for it in terms of time of year and month, etc.? Thanks.
Yeah, in terms of the first question, so the only daily data we used was in terms of those daily moving averages, just to graph the relationship between the infectious disease outcome and COVID-19, to kind of see how the relationship between the pH index and those two. The models are all running at a monthly level, as well as the rates. So everything outside of that is the monthly level data. And then in terms of seasonality, we used 2017 to 2019 data to inform what that seasonality would look like. We also had some autocorrelation issues in the model, so we had to adjust the seasonality. So for LRTI, it's Jan to March and then quarterly thereafter, essentially. And then the seasonality starts from December to February for the diarrhea outcome. And it's just included in the model as a categorical variable, if not sometimes binary, depending on how the time periods were split up and what kind of season they fell over in that further analysis for the different pH zones.
Perfect. Thanks so much.
Thanks. And I think you spoke previously, it was Emil, about interrupted time series. So we have found a bit of a nice, what can I say, intellectual capacity call growing up in terms of interrupted time series analysis, which is nice. Are there any other questions, either in the room or online? I don't see anything in the chat box find. I'm going to go auction style and say thank you, Kathleen. That was a great talk. And thank you, everybody, for being part of our audience.